Hello and welcome to the webinar, Patient-Centered Medical Home, a case study featuring Yakima Neighborhood Health Services. My name is Melissa Da Silva and I will be acting as moderator for today's webinar, which is a production of the National Healthcare for the Homeless Council with support from the Health Resources and Services Administration. This is a 1-hour presentation with the last 10 minutes reserved for Q&A. Thank you again for joining us for this webinar, and I now turn the presentation over to Ms. Anna Gard. Anna Gard is a consultant on all things patient-centered medical home and meaningful use for the Council, and she's acting as facilitator of today's presentation. Anna?
Good afternoon, everyone. Thank you so much for taking some time to join us. We are thrilled to welcome Yakima Neighborhood Health Center. Yakima Neighborhood Health Services is a member of the Council and a 330 funded HCH program. We are excited to share that they are the first community health center in Washington State to achieve Level 3 NCQA recognition for patient-centered medical home for their 8th Street CHC as well as their satellite HCH clinic, Neighborhood Connections. Today, they will share with us a presentation about the nuts and bolts of getting through the NCQA patient-centered medical home application process, including planning and executing the 6 standards, with special consideration of the challenges hurdled when serving a homeless population. Our speakers today include Rhonda Hauff, the Chief Operating Officer and Deputy CEO of Yakima Neighborhood Health Services. She is the past chair of the Homeless Network of Yakima County and serves on 2 subcommittees of the Washington State Joint Select Committee on Health to address issues facing low-income populations in health care reform. She also serves on 2 national committees addressing healthcare for the homeless and public housing populations, and is a part of the inaugural class of the Graduate Certificate Program at GW University in Community Health Center Management. Dr. Philip Dove is the Chief Medical Officer of Yakima Neighborhood Health Services. He attended medical school at Penn State and completed his internal medicine residency at Providence Portland Medical Center. He was named Resident of the Year in 2010 and is a member of the American Thoracic Society from 2009 to present. And rounding out our panel is Michelle Sullivan. MS is the Quality Improvement Coordinator of Yakima Neighborhood Health Services. She joined Yakima Neighborhood Health Services in 1995, initially worked as a counselor with the First Steps program before becoming one of the First Steps supervisors in 1997. She took on the role of Quality Improvement Coordinator in 2002, focusing on the standards for Joint Commission Ambulatory Care Accreditation and most recently NCQA Patient-Centered Medical Home Recognition. We have a robust presentation that will take every bit of the 50 minutes, so I am going to pass it over to our first speaker, Rhonda.
Thank you, Anna. As a community health center, we knew we were a patient-centered medical home. We knew that we did more for our patients than a typical practice. This is our mothership. We refer to it as our 8th Street campus. We have 4 sites, and 2 of them have been recognized so far as a patient-centered medical home. Especially after our Joint Commission accreditation in 2000 and our first federal grant, which was the Healthcare for the Homeless grant in 2005, we knew we were very strong in comprehensive patient-centered care. Our challenge was to demonstrate this through the NCQA process. As we learned through the Joint Commission process, it was important to make the standards work for us rather than for us to try to fit the standards. This is our clinic in Sunnyside, Washington. It's a rural clinic 35 miles south of our Yakima site. This is our satellite Healthcare for the Homeless clinic. It's located inside a chemical dependency outpatient facility. Our HCH site actually scored higher in our patient chart review than our 8th Street campus, largely due to the intensity of our wraparound services, which Dr. Dove and Michelle will go into detail about. It's located directly across the street from the city's transit center, where many of our homeless congregate. This is our newest site. It's located inside a community mental health agency. We didn't have enough patients with our 3 clinically significant conditions to apply for recognition yet, but we plan to in the next several months. Our wraparound service providers, our case managers, behavioral health, and eligibility specialists support our patients at all of our locations. We offer housing and individuals for we offer housings for individuals and for families. Our projects are funded by HUD McKinney and philanthropic organizations like Building Changes. We have 6 one-bedroom apartments for homeless respite care. Our referrals come from our primary care providers, from hospital discharge planners, many coordinating in advance for our homeless patients needing recuperation from same-day surgeries. These are additional services we haven't already mentioned. Some are funded and provided in partnership with the Homeless Network of Yakima County, our local continuum of care. We use the next-gen EMR system. I wanted to mention that we developed a few templates for our HCH team, so their work would be reflected in the EHR system available for all of our team members. This is the Homeless Home. It's a summary of the services provided and a visit. This is the Homeless Encounter Form. It provides the tools and interventions specific to a homeless team member. Many of you are probably familiar with the Arizona Self-Sufficiency Matrix, an interactive tool used between case managers and homeless clients. In Yakima County, it is our community standard for homeless and housing case management and in helping our clients to set their own goals towards self-sufficiency. There are 15 domains, each scored on a scale of 1 to 5. The assessment is conducted every 6 months on each adult in the family. Last year, we built this assessment into our electronic health record. Now, we can individually and collectively measure and quantify our self-sufficiency progress with our homeless clients. Now, I will turn this over to Dr. Dove and Michelle.
So when we first began this conversation, we realized that we had a lot of systems that were already in place that would help us towards NCQA Level 3 medical home. The very beginning thing that I did from my perspective was to make sure that our providers at all of our locations and across disciplines were providing standardized care. That included using templates appropriately, but certainly meant that we had to address the evidence-based guidelines for the 3 conditions that we selected. We selected 3 clinically important conditions to include diabetes, hypertension, and asthma. That way they reached across the ages and also were the most important in our patient population, as Michelle and I will articulate later. This is just a quick review of the evidence-based guidelines that we had gone through. For any providers in the room, you will recognize these as some of the landmark trials and studies in the last decade that have really changed our goals and our management for these 3 conditions. Further, when we were selecting our conditions and looking at the tools available for us in the EMR, we really wanted to be sure we were using the EMR to the best of its ability. So myself and several other supervisors here reviewed the EMR for the available templates that addressed the chronic conditions, as well as the tools that were already available within the system. We had already had a process in place for several years in our peer review process about the usage of some of these tools. We put a real big push on utilizing that peer review process to make sure our providers were doing this every single time these conditions came up. And the biggest thing that really helped us was at Neighborhood Health, we have a philosophy where everybody functions at the top of their degree or the top of their license. So we really integrated the medical assistants into the process here. We knew that if we made it easy for the providers to use the tools in the EMR, then they would use them. So the MA is actually open if the chronic disease template for asthma, diabetes, or hypertension if they know that the patient is coming in for that. Additionally, while we had not made the big push to do NCQA until roughly January of this last year, we did begin about 3 months before preparing our providers to get everybody on the same page. As you go through the process, you do realize you go back on your chart review about 3 months. So the earlier you start, the more successful you're going to be.
From my perspective as the Quality Improvement Coordinator, I started out by reviewing the PCMH standards, looking to see what we already had in place as an organization, and then what we also needed to do to make certain areas stronger or any additions we needed to make. We also created a team that was diverse and had expertise and strength in the areas that we needed to complete the survey appropriately. We did match the strengths, as I mentioned. So Rhonda and myself were assigned to reports and policy. Dr. Dove and our medical team supervisors, who were much more versed in the inner workings of our EHR system, were assigned to things like client records, templates, and workflow. And then as we moved through the process, we met regularly as a team for status updates, review of areas that we felt we had well under control and areas that we felt we needed to put more attention to. So we're going to take you through each element and an example of the things that we submitted to meet that element. So for element 1A, it's talking about written processes for scheduling appointments and communicating with patients. And we truly went through our care guidelines and pulled out every policy that we had that related to appointment scheduling and communication with patients and attached all of those in our application. This is an example of how we were meeting those policies from 1A. So this is actually a printout from a schedule showing that one of our clinic nurses, Cassie, had indeed recommended that this patient be seen from her triage, which was one of the policies that we submitted in 1A. Also more evidence for this element showing that this was an appointment scheduled with our access specialist on a day that they also saw a provider. And you will see as we go through that we drew attention to those elements that we wanted NCQA to pay particular attention to. We did circles, we did call-out boxes to make that very clear that this is what we thought complied with the standard. For element 2A, it's asking for managing patient data, and they give a list of areas that they would like you to be able to pull and manage your patient data on. So we simply pulled a report from our electronic practice management system showing our ability to not only collect that data, but how well we were doing in getting this for every patient. Element 2B, an electronic system for clinical data. NCQA does spell out what areas they would like for you to be able to pull electronic data for. And then we've submitted screenshots showing that yes, indeed, we were able to capture things like height, weight, blood pressure, and BMI in an electronic fashion. This one demonstrates that we can do the same thing for diagnostics.
Element 2C is basically where you start to present your clinical data. This is a screenshot of the charting tool that we used to show our percentage compliance with each of the standards. As Michelle had already talked about, this is our preventative services, allergies, the BMI, height, weight, and several other indications. The key to notice here is that to get NCQA level 3, you do not have to get 100% on all things. There will be some questions that are not applicable to your clinically important conditions. For example, you can see a lot of no's here across head circumference. We don't measure head circumference on adults with diabetes very often. And the same thing goes for number 11 here. We had thought we were doing quite well on advanced directives. You may find that during your process through NCQA level 3 that you identify areas of quality improvement. This was important to us, and I encourage you not to be overwhelmed by the fact that there are places where we need to improve. Use it as an opportunity to improve your care, not to be critical of yourself. Elements 2B and C, to meet these requirements, we really went through and looked at some of the things we were already doing. In this sense, this is an area I'd like to encourage you not to be afraid of NCQA. A lot of these things you're already doing. We're already measuring immunizations. We're asking people their allergies. We're getting their vital signs. Look for the overlap in places where you're already reporting, whether that be meaningful use or to the Bureau, or are you trying to reach other standards, things like JCO. Are you asking advanced directives? Most people want the same information. They're not asking for bizarre things out of you. You will need a clinical team to go through each of the charts that are selected for your 3 clinically important conditions. As I have told you, we chose diabetes, hypertension, and asthma. The nice thing about these conditions is that these folks are some of our sicker people, and what NCQA likes us to show are examples of images or laboratories that have been done, pathology reports as well. Look for crossover. Just because diabetes doesn't require a pathology report, don't forget that a lot of these people are women and they may have pathology from their pap smears. These still qualify. If you do indeed choose a condition, a clinically important condition that involves pediatric patients, you will have more yeses on that charting tool on areas that we did not. Things like head circumference and also growth charts. 4D is about how do you organize your clinical data. Do you structure age-appropriate risk factors into your charting? Do you have a structured template for progress notes? Are you using appropriate screening tools if developmental testing is indicated? And do you have the ability to follow growth charts? Again, the bottom 2 here are much more applicable to pediatric patients, but the top 2 certainly are appropriate for almost all adults. I'm going to take you through some examples here. Of course, this is for our EMR, but most EMRs or even paper charts have similar systems in place. This is for evidence for 2D. What I'm trying to show you here, I'm not sure how it projects across the webinar. At the bottom over here are our age-appropriate screenings, colons, PAPs, mammograms. And we will further talk about the structured template here. This area is additional risk factors for patients based on their lifestyle choices. Do they drink? Do they smoke? Do they exercise? Further, for 2D, they want things to be age appropriate. Our EMR does have screening tools in the social history for pediatric and adolescents. Certainly, smoking is still appropriate here, as is exercise. But things that are more appropriate for children and adolescents include guns in the home, firearms. Are they wearing their bike helmet? Do they have fire extinguishers and alarms? 2D, this is more evidence of our structured progress notes. By problem, a provider is then implementing into the plan what is their progress towards a goal and what are we doing at the next visit. A simple example of the growth charts that our system can demonstrate. And finally, developmental milestones. Again, adults are not necessarily needing autism screening or age-appropriate screening, but this would be significant if you had a pediatric population that had a chronic disease you chose.
For element 2E, they're asking for us to identify those important conditions and what criteria did we use to do that. So a couple of the things that we shared were our top 20 diagnoses, as well as needs assessment statistics from our state and local health departments and the Census Bureau.
Michelle's really clearly articulated kind of the nuts and bolts of why we chose these important conditions, but there are other reasons beyond the numbers, beyond the presentations, beyond what you do report. Certainly, as I mentioned, if you're using it for meaningful use or for the UDS or have to report it to the Bureau, try to use some crossover there. You have a lot of the systems in place already. Also choosing things that are clinically and I cannot say that word, important to society. Those things were important to me as a medical director, that we were using these conditions because I knew in those areas if we directed our quality improvement, we would provide better care. Also for us, diabetes and asthma crossed over for our pediatric and adolescent patients, so any knowledge that we gained there could be applicable to both.
For element 2F, looking at use of a system for population management, looking at things like demographic information, prescription medications, diagnosis or treatment codes. And so we shared some reports that we are able to generate. This one happens to be a callback list for a last HbA1c greater than 1 year or not measured at all. And this comes from our PTSO report services. Also, we are able to generate a report of patients who are currently on Coumadin or Warfarin to then share with their appropriate PCP.
3A is all about showing that you have integrated and adopted evidence-based guidelines into your practice. They want you to be able to show that your templates or paper also demonstrates your implementation of these. You already heard me at the very beginning outline the studies that we had used as a practice as our evidence-based guidelines. What we're showing here next are simply examples of how our system prompts our providers to continue to use these guidelines. Our practice guidelines for 3A, they also wanted to know some of our clinical policies that were in place. So as an organization, what we showed to them were some of the policies citing our professional studies that I mentioned earlier for asthma, diabetes, and hypertension. 3A here, this is an example of how our diabetes template has access to the Framingham risk calculator. On our hypertension template, how you can access JNC7 and how we're already in place for JNC8 when it comes out. And also for asthma, there's no red line here, but the most important thing for evidence-based as far as asthma is the classification. Are these folks mild persistent? Are they moderate persistent? Our system allows us to hyperlink to those categories in case a provider has forgotten. 3B is about preventative service reminders for our clinicians. We all forget in a busy visit, whether somebody is due for their colonoscopy. Your system or your process needs to be guideline-based, and it does need to prompt the provider at the time of service. This is an example here of evidence for 3B showing our health maintenance profile. Areas in red are where a provider or a patient is overdue. Areas in black are where a patient is up to date. This is prompted to a provider at every visit.
For element 3C, practice organization, this talks about encouraging non-physician staff to participate and manage that patient care, having those individuals, as Dr. Dove mentioned earlier, work at the top of their license or degree. So things that we shared that demonstrated this was an example of our medical reminder call policy and then how that is documented in our EPM system. This is a standing order. And then finally, an excerpt from a job description for our patient care supervisor.
Element 3D is all about care management of your important conditions. This is the place where it really was easier for us at our Connections or our Healthcare for the Homeless site than it was at our main site. As HCA sites, you guys are already supplying fantastic care and a lot of support services. This should be the part that you walk into the NCQA thing and say, okay, we've got this. You can drive this all home. Your providers need to demonstrate that they're doing individual care plans for each patient, that they are stating their treatment goals and documenting progress towards the goals, that they're showing a medical reconciliation at every visit. This is also a meaningful use requirement. So again, a lot of these things you're doing. We need to be able to demonstrate that you integrate self-monitoring results, whether those be home blood pressure readings or home glucose readings, or whether folks are doing peak flow meters at home, for example. You also need to assess barriers to care. Again, there are lots of those for folks that are homeless. We document that in all sorts of different locations. So lots of opportunities to demonstrate the evidence for that. And do you notify folks when they don't show up for an appointment or a lab draw? This is just an example of our individualized care plans. Again, the providers were all encouraged and reminded that our patients need to know what their goals are every time. and they need to be assessed at how they're moving towards it. If they're not getting to goal, why are they not getting to goal? In our system, we have several ways to do the medical reconciliation. You've heard us say this several times that it took a team to accomplish this. We have our medical assistants begin the process of a medication review when they room the patients. My medical assistant will ask on each of the meds whether the patient recalls that they're taking it correctly. How are they taking it? Did they ever fill it? Are they using it as needed? Or are they using it differently than prescribed? Once they have then asked those questions, I can then go back through and review the responses and question the patient on any responses that don't seem appropriate. There is a final location at the end of our structured template where we can click that the medications are reviewed. This is an easier element to search when we're running reports, so that is ultimately the provider's responsibility. This is just an example of the structure of our template and of how we work through things with a chief complaint, HPI, review of systems. Here is our ability to show that we are integrating self-monitoring results and also that we are assessing self-management ability. Do the patients have the ability to manage this condition? Do they understand it? What are their barriers? And what are their individual goals that they have set? This is just an example of what we send to patients if they have not shown up for an appointment or to lab for their labs. We try very hard, given our language distribution here in Yakima, to present things in both English and in Spanish. Again, understanding that if they cannot read English, then we certainly have a problem there. Further, given that many of our homeless patients do struggle with literacy, we realize that giving them a progression towards their goal in numbers or in writing may not be as helpful to them. Our system allows us to present graphs that show that they have progressed appropriately towards goal. Here's just an example of an A1C graph, patients starting out very uncontrolled and working towards controlled.
For element 3E, it talks about continuity of care and coordinating that care with both external and then for us, internal services. So one of our real strengths is that we do have our homeless outreach and First Steps outreach services that are integrated into the same EHR system so that we can communicate easily among many different disciplines and many different programs. So this is an example of what we call our standard communication template, which shows coordination of care between the provider, the outreach nurse, and a case manager coordinating care for that patient. In addition, this is also a standard communication template showing coordination of care following an ER visit. For element 4A, documenting communication needs, our electronic system allows us to capture the language that the individual speaks, and we can then pull that back out in a report format. And so this is our report that we submit with our UDS.
4B is about showing that you have the ability to help people with their self-management outside of the visit. We took this to mean several different things. The first is, are you educating your patients? Are you giving them educational resources? Are you teaching them and giving them something to take home to show their family about what their diagnosis is? Our system directly links with the McKesson education system. I will show you examples of that. Other areas that you help with self-management are do you present classes to them? Do you teach them what diabetes is? Do you teach them how to eat appropriately? Do you integrate their self-monitoring tools into the templates? Do you give them meters? Do you help them find blood pressure cuffs at home or peak flow meters? Do you have other resources available? For us, this was a great asset over at the Connections or Healthcare for the Homeless site because of our special programs coordinators, access specialists to help them get onto insurance programs, or maybe helping them obtain a free pap smear or mammogram. Do you inform patients of the plan? We know that if people walk out of the visit and they have nothing written down, they will forget what we're talking about. Do you hand them something that says, you have diabetes, I want you to increase your insulin by such and such? So do you give them a written care plan or a patient plan they can walk home with? The last area here is the support programs, and this is the area I suspect that everyone that's listening has a lot of resources available to them. For our homeless folks, we wrap ourselves around them. We provide social services, whether that be in-house or whether when we're at the mission, do we listen? Do we do counseling over there? Our behavioral counselors go out with our outreach staff to the mission, to our respite housing. Enabling services for us means our outreach folks and numerous other services. Do you provide them with any services that help with their cleanliness or reaching out and bringing them to different visits? This is an example of a McKesson printout on what is an HbA1c. More examples here of how we integrate self-monitoring results. How many times are they using their albuterol at home? Do they still have the self-management ability? This is done every visit, every time for these 3 chronic conditions. People's ability to manage things change as their circumstances change. This is more evidence for hypertension through our hypertension template. We do ask questions about the non-pharmacological management. These are self-management tools that people have. Are they working on weight reduction, alcohol reduction? Are they watching their sodium? Again, further testing their self-management knowledge at every visit. And this is the same that we use for diabetes. Also a link for patient education that goes through our system, and again, assessing every visit what is their goal. This is an example of our enabling services template. Rhonda touched on this a bit. Some of these we had changed a little bit from what came out of the box from our system. This was the biggest help for us. We document every encounter with our homeless folks, as I'm sure many of you do as well. How are you doing with your case management? These are great things and great examples that NCQA wants to see.
For element 5A, our electronic prescription writing, this is a report that we did create specifically for PCMH recognition. This looks at both of our sites, our 8th Street and our Neighborhood Connection site, and looks at the number that were e-faxed, e-prescribed, and then written. And with this particular program, we're able to set goals for ourselves and then monitor our progress towards those goals.
5B is, does your system provide support for prescription decision making? This is just an example of how our system is able to alert us if we're prescribing a medication that a patient has an allergy to, or even more importantly, does the patient have a condition or another drug that may potentially interact? Many systems have different levels that you can set the alerts. We chose to set our alerts at the highest level so that our providers are reminded at every encounter of a potential interaction. Additionally, for 5B, we did show that our system had the ability to help us out with appropriate dosing. This is more important for pediatrics, but certainly if you have geriatric homeless patients, you need to be aware that dosing recommendations do change based on their age and their weight. 5C is about prescribing this support again. Are we doing this in an efficient way? You need to be able to show one of 2 methods for cost-effective prescribing. So do you get electronic alerts about generics when prescribing a brand name, or are you able to offer alternatives based on a patient's formulary data? Now, some of our patients certainly may not have insurance, but some of them will. And can your system tell you that it is covered by their plan or not? 6A is about test tracking and follow-up. This is simply a report of laboratories that are either completed or not, and we run this by provider. If labs have not been completed, we have the ability to follow up and see did the patient show up or what is the problem there. More evidence for 6A, your system has to show that you're able to integrate the laboratories into your system and that it does allow you to respond appropriately. We have a policy here that all labs are responded to every time, whether they're normal or abnormal, and that they must be done within 3 days. We did present the policies for this as also evidence along with these screenshots. This is an example for 6A of the evidence of how we notify patients of normal laboratories. If they did not get a phone call, they get a letter. Abnormals are always in a phone call. 6B is about the integration of the electronic tests, both for imaging, laboratories, and pathology. This is just a screenshot of our LabCorp ordering formulary. As a provider orders the labs during the visit, they then come back to us in this format. The system alerts us to normals and abnormals that are set by the system and also are able to be modified by myself. Black, I always tell folks, is normal. Blue and red, I have to explain. Patients are shown this screen at every visit. So if they have questions beyond what I'm explaining, they can draw it out and we walk down the line. 7A is about referral tracking. Placing a referral is no good unless you can follow up and make sure that a patient made it there. The highlighted areas here are, as Michelle had noted earlier, we didn't want NCQA to have any questions about what this screen meant. So we put big giant boxes around the fact that we integrate their reason for going and that we follow up. Did they complete? Did they cancel? What was the problem if they didn't show up?
Element 8A is all about measures of performance. The first slide shows you our active monitors for diabetes. Again, we're able to establish a goal and then monitor our progress towards that goal. This is also an example of a measure of performance. This is looking at appointment accessibility. Element 8B is about patient experience, and what we shared with NCQA was our entire patient survey. We do surveys ongoing each year, summarize them at the end of the year, and we shared our entire survey. Element 8C, reporting to physicians. So this is just an excerpt from our patient survey where we're looking at quality, how well things were explained, if the patient felt they were treated with respect, and if their questions were answered. And then we track this over time and share it with providers at their evaluations. For 8D, setting goals and taking actions, as I mentioned before with our PTSO report services, we are able to document a goal and then over time look at our progress towards that goal. For element 8E, we were asked to look at the National Quality Forum measures, and there was a certain number that we needed to be able to report on. And many of those things were things that we were already gathering and reporting on for other entities, as Dr. Dub had mentioned. And so we just pulled together those different reports into one location and put them against the NQF standards. Excuse me. For element 8F, what things do we report electronically to external entities? Well, our big one is our UDS report, and so that's what we included here as an example. So all of the portions of element 9 are about having an interactive website and email system with patients, which at this point we were not meeting. Our patient portal was not up and running when we submitted this. But this is just another example of you don't have to get 100% on everything to meet that level 3 recognition.
So we're kind of wrapping up here, and at the end of the NCQA process, and you heard me say at the very beginning that we went into this feeling pretty confident that we were going to be able to meet their standards, but also hoping that this would be an exercise for us as an institution, as an organization, to grow. Where were the areas that we were not doing the best at? 3 here that I have highlighted. You know, advanced directives are very important. They're no less important for our homeless patients, and as a provider I would actually state that it's probably more important that we as a medical home know our patients' wishes in the case of an emergency. You know, our homeless folks don't necessarily have family that's close by, but if they get admitted to the hospital, I want to be able to pull up very quickly what their wishes are. we noticed that we weren't doing so well on this. This is something that we're working on actively as an institution, and I hope that this will improve in the future. BMI is something we thought, well, gosh, we measure heights at every visit. We did really well with this in children, but we weren't necessarily measuring the height on our adults. This is a measure that you have to report to many different entities. Since the NCQA process, I think I see this now about 99% of the time. The last was tobacco cessation. When we were reviewing those risk factors, one of the areas that we identified was we weren't documenting in a correct place tobacco cessation. This is a meaningful use measure and something that is going to be very big in the coming year. So we have completely changed our workflow around this and how our providers document that we are advising for tobacco cessation. It is now in a reportable and extractable field instead of being in a patient plan or a progress note where you cannot pull it out.
All right, now looking forward to the PCMH standards for 2011, there are some areas that are different from 2008 that I see as potential challenges for us. Some of them are just in terms of how do we pull that data. So the after-hours access, we do have after-hours access for our patients, but how will we be able to pull that information to show that we are meeting our standards and guidelines for how quickly patients are called back and then getting that information into the patient record? A lot of these things go hand in hand with meaningful use, and so then as we're meeting those standards for meaningful use, they will also help us along with PCMH 2011, things like secure electronic systems for patients and families. 2011 includes information about vulnerable populations and then some special things as an organization that we do around that, training and communication skills related to dealing with those vulnerable populations, and some additional standards around population management. Before, the 3 clinically important conditions that we chose were asthma, hypertension, and diabetes. Now, one of the 3 has to be related to unhealthy behaviors, mental health, or substance abuse. And then you need to be able to pull out information specifically around that and around those vulnerable populations. For medication management, and we currently gather information on over-the-counters, herbals, but to specifically say that on this date we asked those questions, again, is something in our system that we will have to figure out how to pull out. As I mentioned before, a lot of these things are meaningful use related, so that electronic exchange of clinical information, electronic data reporting to CMS and other public health agencies, those things will be coming, but they are definitely different than our 2008 standards.
So in summary, there's one question, and the question has to do with how we handle outside referrals or to specialists. And we did create a report, and we, again, using the next-gen system, and any system has the ability to write reports, I suspect, to be able to track unreconciled referrals. And so what we do is we run reports on a regular basis for labs, diagnostics, and referrals that enable us to track referrals that have gone out of the system but we don't have reports back for. And so we run those on a regular basis and then give those to the different team members to be able to follow up on. The final comment I will make before turning it over to Anna is that the tools that we've gone through, again, we really started with the work that we do as a community health center to really build on the strengths of the team that we have, and then tried to make the standards work for us. And so we hope that going through the nuts and bolts of the standards as we've done today are helpful to you. So with that, I'll turn it back over to you, Anna.
Thank you so much for outlining each standard and how you approached in a very systematic way addressing the standard and troubleshooting some of your barriers. I would like to mention that the Council will offer a pre-conference institute on Tuesday, May 15th of 2012 in Kansas City at the national meeting to look at greater depth on patient-centered medical home and meaningful use of HIT. We got a very quick overview of the 6 standards and the different elements. This interactive workshop will provide a structured approach to illustrating each of the standards as well as a crosswalk with the meaningful use with specific emphasis on the homeless population. So I encourage you to consider attending the pre-conference if you'd like more detail. In addition, I did actually want to throw out a question because this is one we hear from our grantees. Did you apply for or receive any special grants or funding to support the PCMH recognition process? Because it is time consuming. So I wondered if you got any support or if there are any regional or state initiatives that give you some incentives to be recognized.
We did not have any special funding to initiate the process. As most people know, the community health centers had the opportunity to apply for $35,000 earlier this year, and we did apply for that. What we learned going through the process was there was a lot of manual searching that we did in the chart entry that would be great the next time we go through this in 3 years to be able to do more report writing. So we actually, when we did our application this year for the $35,000, we used it to help to engage a report writer so that we could take our manual process and electronify, I think is the word, that process so that we can produce more reports to help us standardize that. The reason that we decided to do it at the time that we did was because of the encouragement of the Bureau, and we know that there will be funding, will be more geared toward centers and programs that are patient-centered medical home recognized. And so we again felt confident that the work we were doing was already in that direction, and it was a matter of just putting it toward the standards. And it's really quite something to know it, and then the other thing, and then once you really can see it laid out on paper, it's a great feeling. And you know, I wouldn't hold back from at least doing the self-assessment in the beginning, because I think people will be amazed at how close they are just doing that initial self-assessment. With a little work, you can really push yourself to the full recognition.
Thank you so much, Rhonda and Michelle and Dr. Dove. I am now going to pass the baton over to Melissa, and she will moderate any questions.
Thank you, presenters, Ms. Rhonda Hauff, Michelle Sullivan, and Dr. Dove. On our website, you will find other webinars on the NCQA process, as well as other case studies of patient-centered medical home. And I see a question here coming in from one of our participants. And the question is, when did you implement NextGen, and do you have any lessons learned to share with us?
Well, we implemented the practice management side in 2006, and the EHR side, we just finished our 3rd year, and I think we've in terms of lessons learned, hopefully we've shared some of those along the way, but I think we're learning things all the time. I'm looking at my teammates here and seeing if there's anything special that they would want to add to this.
So this is Dr. Dove. The only thing I would say about, lessons learned from an EMR is I have now been on probably over at least 8 different EMRs in the course of my young medical career. The lesson I would say is that there's no one that's perfect. So, every EMR has different strengths and weaknesses. The big lesson is when you go into this process, sit down with your team from many different disciplines in your organization and figure out what are the options available. When we first looked, in the beginning, our providers were not using the chronic disease templates as much as we are now. And so we didn't have the ability to report and standardize things nearly as well as we can now. By making use of the tools that are actually inside the system, we've standardized our care, we've actually sped up the office visit, we've really moved things along. So the one example, or the one lesson that I would say is, really explore your EMR or your systems before. And, everything has goods and bads, and just utilize what you've already got.
I think the only other comment I would make is keep it simple. Don't make it harder than it has to be. I think we learned that going through the Joint Commission process. Again, I think we tried to take some lessons we learned through that process and bring it forward to patient-centered medical home. And I think the lessons that we learned really came from the Joint Commission process into patient-centered medical home. So.
Thank you, Dr. Dove and Rhonda Hauff. And how did you manage training your staff on NextGen? Rhonda?
Well, we have the fortune of being part of a community health center control network, and so we share NextGen with four other community health centers in Washington State. So best practices we really learn from each other, and we were the fifth center in that group. So we had some examples from other centers and what worked and did not work for them. And as each has their own workflow, we're sort of a medium-sized center. And again, we were the CHC lead in developing the homeless templates, and then Michelle was the CHC lead in developing our public health templates in the maternity support services program. So we had some of that we sort of learned as we went. And again, with each center having their own workflow, it was really upon the team leads here within the organization to do the training based on what met the needs of the team. Dr. Dove has already talked about how the training was really guided by the structure of the templates, allowing each member of the team to work to the top of their scope, and that was a real driver. And NextGen, fortunately, provides the structure that allows us to do that.
So the only other thing I would say about training is, when we bring a new provider in, I sit down with them and I take them through the system and show them how to use the tools that are there. I realize that if we get people at the very beginning, most folks are new to the system, so if we teach them at the first time, then they're more comfortable using it the way that fits the workflow the best. We continually train on NextGen as problems come up, as new upgrades come out, as we shoot to resolve issues. We have a provider meeting twice a month. One is for an in-service every month. If it affects all providers, adults and peds, then we present those changes there. If it only affects one group, then we present those changes in more training at the individual provider network for either adults or peds.
When we first implemented our EHR system, we also trained a group of what were called super users who acted as mentors then in the rooms with the providers as we rolled it out. And we kept those partnerships going for probably 3 days to a week with each group as we brought them on, so that they had a go-to person to support them through those processes as well.
There's a question here that I see that asks if we considered the PCMH recognition through the Joint Commission process, and we really did not, and primarily the reason was that when we were ready to go through it, the Joint Commission standards were not ready, and we were anxious to go through it this spring before the Joint Commission standards for PCMH came out, and that's the primary driver for why we chose to go with NCQA. The Bureau had contracted with NCQA, had signed their contracts at the point that we were ready, felt we were ready to proceed, and so that was the primary driver why we went forward.
Thank you again, Anna Gard, for facilitating this presentation on patient-centered medical home. Thank you, presenters, Ms. Rhonda Hauff, Michelle Sullivan, and Dr. Philip Dove, for an excellent and dense presentation on your PCMH process. Thank you, participants, for joining us for this webinar, Patient-Centered Medical Home, a case study featuring Yakima Neighborhood Health Services. This webinar has now concluded.